and I am joined by my esteemed colleague, Jeff Tucker, who is the Vice President of Business Development and Innovation for the Marshfield Clinic Health System. We are the hosts of our webinar Wednesday, and very pleased to be with you once again. This is a co-sponsored event from Security Health Plan and Marshfield Clinic Health System, and we try to bring you guests every week that are going to shed light on how things are going on within our health system, and hopefully bring you a lot of information that you can use to run your business as you manage through not just the pandemic, but anything that you have that might be health related. So I'm going to just start with a couple of housekeeping items, and then I will pass the baton on to Jeff. But just so you are aware, this is being recorded. We will send out this presentation to all of the pre-registered guests once this is completed, along with the presentation. So feel free to peruse that at your leisure in your email. It is also posted to the Security Health Plan website under our COVID-19 page. So please look for it there, as well as all of the past episodes. You can find them there as well. There is a chat feature and a Q&A feature, and we do encourage you to ask us questions. We will do our best to get those answered during the presentation, and anything that you have that we need to address afterwards, we will go ahead and do that afterwards as well. That feature is in the upper right-hand corner of your screen. There's a Q&A. Just open that drop down. You can type the question right in, and we will make sure that gets addressed. And without any further ado, I will hand it off to Jeff to complete the introductions of our esteemed guest. Jeff?
Thank you, sir. And Chris, you have our presenter to blame for not becoming the next internet sensation. You would probably be the next Justin Bieber. And, but now you are anchored by your co-host, myself. When we launched this webinar series, we talked briefly about just a little bit about our background, and I had mentioned that I joined our health system as a result of all of the dynamic things that are occurring here, becoming a nonprofit health system, and all of the parts of it that have developed and been made into a cohesive nonprofit health system. And I quite literally resigned my position in Minnesota as a result of the words and vision of the person who is about to present, Dr. Susan Turney. She's a dynamic leader. She's done, it's just been amazing working for her. So I can't even pretend to do an unbiased intro. So that's my proviso going into this. I had a system crash just prior to the launch, so I have to switch screens. Hopefully this is still working. I'm going to touch on the highlights. I worked with her enough to know that if I read her whole bio, that she'd be a little bit embarrassed. So Dr. Susan Turney is the CEO of the Marshfield Clinic Health System. She joined September 1st, 2014 as the CEO. So you just had an anniversary, Dr. Turney. Congratulations. Prior to her current position, she was president and CEO of the Medical Group Management Association, the leading association for medical group practice administrators and executives from 2011 to 2014. She was CEO and executive vice president of the Wisconsin Medical Society from 2004 to 2011. She is a fellow in the American College of Medical Practice Executives, having earned that distinction in 2005. Prior to that, for 22 years, from 1982 through 2004, Dr. Turney was an internal medicine physician at Marshfield Clinic and served in education and leadership roles and as medical director for patient financial services from 95 to 2004. Today, she's going to talk about the challenges in rural areas for healthcare. The COVID-19 pandemic has shone a spotlight on those challenges and caused us to think differently. Dr. Turney has looked for innovations and partnerships that have blossomed in Wisconsin in response to the pandemic. And she'll talk about the collaborations with health systems across the state and the country that are making a difference in our rural communities. So with that, I will turn it over to Dr. Turney.
Well, and Jeff, thank you for that introduction, and I truly appreciate it. And I really, it is a pleasure to be with all of you today. And this is an understatement, but these truly are extraordinary times. You know, seriously, our society has not faced a challenge like this in 100 years, actually since 1918 when the flu pandemic hit. And interestingly enough, that pandemic occurred just as Marshfield Clinic Health System was getting started, as we were founded in 1916. So we're 104 years old. And yet the landscape of rural health before this pandemic began that has made this crisis uniquely challenging for us is something I want to touch on just a little bit. So I want to let you know that the deep-rooted systemic problems that rural communities face is real. It was present before the pandemic, but with the pandemic, or I should say, and with the pandemic, they have clearly been exacerbated. So I think the important things to share with you in our community is to talk a little bit about how we have innovated, the things that we've done to collaborate with others to really meet this moment. To start with, however, though, I do want to give a quick overview of Marshfield Clinic Health System because we look different than we did 6 years ago when I joined on September 1st, which happened to be Labor Day. Well, Dr. Murley insisted I meet with him that day, which ended up being a 6 or 8 hour meeting. So for those of you who know Dr. Murley, I was exhausted and he was just starting. So what I'd now like to do is have you go to the second slide, Chris. As I mentioned, we were founded in 1916. And we've grown to become one of, and I believe we are, the largest purely rural health system in this country. And when we talk about fully integrated, what this means is that we have the physician and other clinician providers, over 1,200. We have a provider-sponsored health plan, security health plan, and we also have acute care facilities. In addition to this, we do have the largest private medical research institute in Wisconsin. And right now there are over 50 clinical locations, and from one hospital in 6 years ago to 10 hospitals across central, northern, and western Wisconsin right now. So I think it's good to sort of do a little level setting to know that in the last 6 years, we have changed dramatically. So I'm going to sort of skip any more boilerplate issues because I really want to talk about the state of rural healthcare. So I'll have you go to the next slide, Chris. I think what is really important to understand about the impact of COVID-19, again, is that rural healthcare was in profound crisis for many, many years before the pandemic. Of course, being hit with a once-in-a-century crisis, you could guess that many rural health systems are barely hanging on. Before the pandemic, Modern Healthcare, which is an industry publication, reported that 21% of rural hospitals were at high risk of closing. That equates to 430 hospitals across 43 states, and that includes about 150,000 employees. The other thing is that Wisconsin had not been on the watch list prior to that report. Wisconsin now has, I believe, 6 hospitals that are on that watch list in our rural communities. In addition, we do live in healthcare shortage areas. Before the pandemic, the federal government estimated that actually about 50 million rural Americans lived in healthcare shortage areas. And that's where the number of hospitals, family physicians, surgeons, paramedics have really declined to a 20-year low. We also know that there are 60 million people that live in rural America. So that means that 5 out of 6 rural Americans are living in an area that is relatively deprived of health services. The impact of a closure of a rural hospital is profound. We know from the socioeconomic data that has been collected that about the per capita income falls in a community over 4% when a hospital closes, and unemployment goes up almost 2%. This has been published in multiple different publications, most recently in health services research. So we can't underestimate the fact that some of the foundational challenges for rural America is simply our demographics. We know that older Americans are older, sicker, and poorer, but we also know that rural Americans are older, sicker, and poorer than their urban counterpart. In addition, our median income in our 45,000 square miles that we cover is about $8,000 less than the state average. I talked a little bit about being older, sick, or poor, and we talked about the poor piece, but rural Americans do suffer higher rates of obesity, chronic disease, and mental health issues. At the same time, they're having less access to primary and specialty care. So these unique challenges also include things like a scarcity of transportation options. There's a profound deficit in broadband internet access, which really does compound our ability to provide services to our rural citizens, especially in terms of accessing health care. It's estimated that about 16% of Wisconsinites lack broadband services. I do know that the Pew Research has looked at rural America in general, and they have noted that about 12% of people lack broadband access. So we tie that into the fact that we're looking to do a lot more virtual care, and I'll talk about that a little bit more. You can see the challenges that we have if people don't have broadband access or smartphones to communicate. We also know that over the last year, about 60% of our missed appointments were because of transportation challenges. That's huge. These are the things that we need to fix besides fixing our patients when they come to us with problems. Again, the demographics of our patient population does have an impact on our economic health as a rural system. And because of the fact that we care for aging and generally poor populations, we do see and have a growing number of Medicare and Medicaid patients in our practices. We also know that the reimbursement in caring for those patients is less than the cost of providing that care. The result is that the majority of the patients we see, we lose money caring for. It also tells the story of the economic impact that it has on our business community. So if you go to slide 4. As we think about how this all compounds the rural crisis, I haven't painted a real rosy picture because of the fact that we are uniquely challenged in terms of accessing healthcare and in terms of basic socioeconomics. So when you think about where we started from, and then in March, some people have said this was like being hit with an earthquake and now being struck by a tsunami. Doesn't matter what terms we use, we were hit by something bigger than we had ever experienced. And I'm very happy that we did not have a major surge of COVID patients like they did in many other parts of the country. However, our communities have truly felt the impact. We felt the impact of isolation. We felt the impact of job loss. And certainly, I can't believe there's anyone that has not experienced some change in their daily life. So just to give you some perspective, in the first month of the pandemic, our system largely shut down all non-urgent care. During that month, we lost $70 million in revenue. We had to make some changes, and to sustain our viability and to hopefully allow us to create a path to vitality, we had to furlough some of our staff, we had to redeploy some staff, and there were also wage decreases. And as our communities also shut down and people became more isolated at home, there was a whole new slate of health related challenges that emerged. And I'll just share a couple examples because I think it keeps it in perspective. If you think about someone who is some mobility issues, a 75-year-old widow who lives alone is more isolated than ever because of the pandemic. Clearly, we know that loneliness is a major, major health issue. In fact, the CDC reported that loneliness is associated with a 50% increased risk of dementia. It's associated with an almost 30% risk of heart disease and stroke. And there are a lot higher rates of depression, anxiety, suicide, and addiction, drug abuse. If you think about what's happened to our families, they're a young parent, they're trying to balance working from home, they're taking care of their kids who have been pulled out of school in some cases or daycare. So they're trying to manage their job, teach their kids, keep the house up. Think of the toll that it takes on our communities. And then there's the family that couldn't afford to miss a single paycheck in the past and has now missed several and is at risk of eviction, trying to put food on the table. So these are real things that we're dealing with. And I believe that we've done a lot to help our communities, and I'll talk about that. But the loneliness, the stress, the economic crisis, they all have an impact on a person's physical and psychological well-being, regardless of socioeconomic status. And these are perhaps the hidden or less talked about costs of this pandemic. We know we had the wave of COVID, and we certainly have been taking care of COVID patients and have many more who have tested positive. But the hidden or less talked about costs of this epidemic are the physical and psychological well-being of the people in our communities. And you may have actually heard this term. We call these social determinants of health. These are things that happen outside the clinical space that do impact your health. These are like education, income, access to healthy food, social relationships, access to transportation, and much more. So I'll have you go to the 5th slide, Chris, please. So what are we doing? Because I think it's important for you to understand that we don't sit within our 4 walls and just worry about that part of people's lives. We worry about people's lives outside of our facilities, whether they're our patients or whether they're not our patients. So the question is really, what are we doing about this, and how are we reaching people and caring for them during these unusual times? And I think that one of the answers to that question, and one of the silver linings, if there is one, of the pandemic, is the fact that we have seen increased collaboration across the board. We're working more closely than ever with public health, with our elected officials, and certainly our fellow health systems locally as well as nationally, to really share information, because there is no playbook, to share best practices, and to really educate our communities on what is needed. Because we are a large integrated rural health system, we felt strength comes in numbers. So we brought together an ad hoc group of rural health system executives from across the country to really engage with senior leaders at the nation's capital. So we met with senior staffers at the White House. We met with the secretary and the head of CMS at the Department of Health and Human Services, and talked about the COVID impact and the issues that are unique to rural communities, and what specific needs that we would have based on what exists in terms of the social determinants of health and what we need from a healthcare perspective. Of course, we've also been in very regular communication with policymakers at all levels of government about the impact, working with our congressional delegation, the Wisconsin delegation, staff, and other committees, and have spoken on a routine basis with senior leadership in state government, including the governor and his senior agency leadership. So this collaboration, this communication, might not have been happening as much in normal times as it is when you have to have a coordinated response and try to figure out how to sustain your business, healthcare or other, on a day-to-day basis. But I would say that we're also very, very proud of what we've done in our communities. And I toured some of our facilities in northern Wisconsin at the end of last week. And patients and their staff are very appreciative of what we're doing to help them as we reach out beyond our clinical borders and as we reach directly into our communities. So we do have our community connections team, which is a vital part of our organization and has helped us pre-COVID. But one of the things we were able to identify during this crisis is that the gap in the social determinants of health are greater, I think, than many of our communities realized. So what we've been able to do is connect different agencies in our community with some of the resources that they need to help people who live and work in our communities, to help them find resources like transportation, to help them find affordable housing, to look at ways to provide childcare, healthy food, and more. So one of the things that we did was we opened up the service not just to our patients that are Security Health Plan members and not just to patients that come into the Marshfield Clinic to be seen, but after we heard the challenges from our community partners, we opened all of this up free of charge to any community-based organization that was serving some of our at-risk members. I'm proud to say that we were one of the first in Wisconsin to offer a COVID-19 community support fund. We provided over $400,000 to local organizations to fill those community needs. All in all, about 70 organizations did receive funding. We also launched an iPad donation program where we collected iPads from our communities and repurposed them through our IS department and then distributed those to our patients who are suffering from social isolation, and certainly provided them a way to connect with not just us, but their family and friends, and also particularly those that had a member in the hospital when no visitors were allowed into the hospital, and they really had very little other way to connect with the outside world. And another area that I'm very proud of and something that we worked very diligently on is sort of at that other end of the age spectrum, and that's sending kids back to school, which we know is a very immense challenge and very complex. So regardless of what school districts have decided to do, we have been working hand in hand with them to really provide support in a variety of ways. And I'll give just a couple before I close. Through the AmeriCorps program, we've created a virtual classroom programming and activities for after-school program students to do at home, to give parents some peace of mind when they're at work till 5 or 6 and their kids are in their home after school. In July, we also hosted a virtual event, and this is really important because I talked already about the behavioral health impact of what we're going through. We have a program that's called BEST, B-E-S-T. And what this does is it screens kids for behavioral and emotional issues. When we held this event in July, we had over 40 school districts attend the event. And what we did was provide teachers with the tools that they need to assess student behavior. We have also been providing and facilitating a series of statewide, what we're calling reopening calls that do allow for a forum for schools and after-school programs to really share and discuss protocols for this year, as well as a guide geared toward parents to help answer their questions and really provide tips that they need in this most unusual year. So I wanted you to know that this deepening of partnerships within our communities has been essential to caring for people during these times. And I'm optimistic that we can continue to provide that health infrastructure that we need. So I'm going to close with just a couple comments around virtual health, because I've commented already on the lack of broadband and the lack of smartphones and the lack of computers to be able to communicate with providers at the health system. However, we know that this is going to be an essential part of our business going forward. And obviously, because of the rural nature of our health system and the fact that we've been doing telehealth for over 30 years, we really need to continue to find ways to reach the people in Wisconsin that prefer care virtually or are challenged to get here simply because of the time to drive or family members having to take time off work. So I would say I'm very proud of the people who see patients within our health system. Between March and June, we completed over 50,000 telehealth encounters, which is 4 times the total number that we provided in 2019. And for those patients who really like receiving care this way, in terms of convenience for a multitude of reasons, it actually can be much more efficient. And we found that in behavioral health, as an example, they were able to see more patients during their clinical practice time because of the turnover of exam rooms and being able to extend their days so that patients could actually get in for their behavioral health concerns. And I have to say the government has been very eager to provide easier access to providers for reimbursement for these services. But right now, we don't know what that's going to look like after the first of the year, and certainly don't know what the private sector payers are going to be doing. So the paradigm that we're living in is changing daily, but I do believe we're making a difference in people's lives. And right now, we're at about 95% of the capacity that we were at prior to COVID. So we know that these frequent touch points and the way we are caring for patients, both for chronic diseases as well as acute conditions, is about where it should be based on our prior history. And then lastly, one of the things that I wanted to talk about, because I didn't explicitly state it, but cost of care is at the top of everybody's mind, and I get that. We're doing what we can. We are living in an area where we are very challenged because of the high percentage of patients that we see that are government-funded program patients, that the cost of providing care is not covered by the payment from Medicare and Medicaid. However, by looking to different ways to provide care like telehealth, and home recovery care, we can dramatically decrease the cost of care. And we take care of many patients in the home that would have to be hospitalized if this program was not available. And it's because of the state-of-the-art telehealth and the ability of our caregivers to go into the home and our physicians to actively communicate with and monitor the patient virtually. And after several years of running this program and seeing its growth, despite the fact that we've added hospitals, we know that a typical hospital admission cost is 17 to 30% less. There are 55% reduction in readmissions and a 38% reduction in average length of care, which translates to a lot of dollars saved for the patient and for the plan. And the satisfaction rate for that program stands at 98%. So I know I shared a lot of information. It's exciting to be able to do that. I think the crisis has accelerated our willingness to change, innovate, try new things. And I know that we have taken big leaps forward, and that's going to continue. So whether it's community engagement, cross-sector collaboration, recreating a better healthcare system, I do know that it will position us to sustain for that next 100 years. So I know we are bumping up a little bit against time, but if people have a few minutes, I'm glad that you listened. And Chris, if able, I would be more than happy to take a few questions, or Jeff, who's ever running that.
Yeah, we'll tag team it, Anya, and throw a couple of questions at you. Thank you very much. Really great information. Certainly backs up some of the other presentations we've been hearing from our other guests over the last few weeks related to telehealth and certainly the lack of access to broadband. One of the things, Susan, that you had mentioned was the collaboration with other rural healthcare providers across the country. which I think is just great because, some of the best ideas come from those that we just steal from the others. So from our employer's perspective, what might be some of the possible outcomes they could see in maybe like in real time, our system changing is how we deliver to them in this rural market as a result of that collaboration?
Well, I think a couple of things that I already mentioned. Certainly, virtual healthcare has been around for 30 years. We don't know what the right balance is. Is it 10% of patients are seen virtually? Is it 50%? Is it certain conditions? Is it people with chronic disease that need, very close monitoring? And by sharing and having discussions around this with CEOs from across the country, certainly gives us a better sense of what's possible. And then we have to decide what's going to work for us. But that is a great opportunity to get sort of real-time lessons learned. I think the other thing is that for rural health systems in particular, although we do have a rural health collaborative in the state, the issues that we face as an integrated delivery system and being as large as we are, oftentimes are different than a smaller rural hospital or a critical access hospital. So talking with Geisinger, talking with Dartmouth, talking with some of the other systems in Montana, for example, that are more rural, we need to bring our voice to the table in a way that has not been heard in the past. Rural healthcare has not been a focus at the federal level. Now it is. And we hear the Secretary Azar, we hear the administrator at CMS, Seema Verma, talking about the need to address rural healthcare issues. That helps us because we know programs are underfunded. We know that payer policies don't always keep pace with the evolution of care. For example, Medicare for Security Health Plan in the Advantage program covers our home recovery care, but Medicare fee-for-service does not yet.
Right.
We have demonstrated high quality, lower cost, and tremendous patient satisfaction. So again, being at the table, having a bigger voice certainly has a bigger impact.
I have one question for you, Dr. T. At the beginning of your presentation, you mentioned basically the critical state, particularly of rural healthcare. Clinics are closing, community hospitals are closing, yet Marshfield is making a substantial investment to basically run into those markets, open up hospitals and clinics in the rural market. Why?
We believe in our mission, and we want to take care of patients, families, and our communities. And I honestly don't think there's anyone in the country does rural health as well as we do. And I think the fact that we also are committed to educating our workforce of the future, we are also committed to the research that will help us evolve the way we deliver care, sets us apart from others. But we want to take care of people. And we're not afraid to take some calculated risks to make sure that our patients and our communities are served in the way that they deserve, right? Just because we're rural doesn't mean we shouldn't have access. And that is critical to us.
And I have one more question related to that one. So drawing in medical professionals to the rural community has been a challenge. My dad was in hospital administration his whole life and ran a small hospital in a rural community. And I remember from back when I was in high school, this was always a topic of conversation, was how do you recruit the medical professionals to the area? What can our employers do? Because obviously having good healthcare in their communities is a requirement, kind of like having good schools. You want to have those to maintain your business and to become really vital in that community and to grow. What can our employers do to partner with us to help draw in more medical professionals to their areas?
Well, I think essentially, first of all, you're right. We know that the headwinds for recruiting are huge for us. We know that less than a handful of residents completing their training programs want to work in communities less than 50,000. And that number goes down when you think about the number that want to practice in 25,000, in communities that are less than 25,000. And then you think about us, where most of our communities that we're in are less than 2,000. So we have a huge challenge recruiting physicians into our health system. We've done an incredible job. And in fact, I think just this summer are bringing in 62 new physicians across our health system. But it's not just physicians, it's nurses, it's therapists, it's technicians, it's administrative staff who are partners with the clinicians to really support what they need to get the work done. So it is a huge problem. We also know that we are the largest employer in the northern half of the state of Wisconsin. And I mentioned what it looks like when a hospital or a clinic leaves a community. It has a big negative impact. So I wish there were a simple solution, but I do think it's just continuing to work together with our community partners to make sure that our communities are meeting the needs of the people that are living and working within those communities. I am going to mention another challenge that we have, however, and it's a result of the pandemic, and I think it's extremely important. And this is a whole new ballgame for us. And I mentioned the fact that the challenges of families right now with children, childcare, and with school. A high percentage of the people that work within our health system are women based on the profession, nursing as an example. And the challenge is if our nurses leave, there's no one across the street to recruit. So when our nurses and our environmental services staff or finance staff just go down the list of different departments, you now have a family, particularly a woman in many circumstances, responsible for 50, 60, 70% of the care at home, taking care of aging parents, trying to manage their children, and also teach school. We know that in some health systems across the country, they have estimated that they may lose as much as 20% of their workforce because of the stress on families, men and women. We also know that many are just allowing staff to go part-time. That creates a lot of challenges for us. So we are really looking into this issue to try to figure out how can we create the opportunities for childcare, for housing, for food, but also the flexibility for our workforce. Having 10 hospitals, that's a 24/7 hour operation. When we had the clinics, that was, more of an 8 to 5, 5 days a week. So we have a whole new set of circumstances that we're facing. And we have a cross-functional team throughout our enterprise looking at what we can do to support our families right now, because it is a crisis and we need to do everything that we can. And that is another area where we will be reaching out into the community for resources and for help, collaborating, again, to meet the needs of our workforce, but our communities in general.
Great. Thank you very much. I don't think we have any other questions, but if you do have other questions, please do use the chat feature or you can email them directly to us. And I know, Dr. Turney, you have your information out there. Oops.
Chris, sorry, there was one question received that I think is important to get answered.
Okay, go for it.
So, sorry, if you have a second, Dr. Turney.
Yes.
Okay, so the question is, as we move into another flu season, along with the continuation of COVID, what would you anticipate the system's response would be to providing patient services? And the second part of this question is, would a halt to patient services be a possibility similar to what happened this past spring?
Not sure where to start in answering this question, but I'll try to cover all of the points. We do know that we have learned as this pandemic has progressed, and what we did in March and April and May were different in June, July, and August, and will be different in September and October. We do also know that when people go indoors and have closer contact, in general, children go back to school, infectious disease begins. And there are multiple viruses and bacterial infections that we see in a cyclical nature, particularly in the fall. We also know that many of these symptoms are the same, whether it's COVID, influenza, or enterovirus, or some other disease, with a little runny nose, maybe a low-grade fever, a little sore throat, some congestion, maybe some GI symptoms. So it is going to be hugely challenging to determine what we need to do as we progress through this flu season. And we're talking about it intensely right now, because until you know someone doesn't have something, it's hard to let them continue coming to work. And being able to have the testing capacity and capabilities to rule out COVID is going to be critical. But we also have to have that same capability for influenza. I mean, I would like to say that we're going to continue to do business as usual, but I can't make that promise because I really don't know what's going to happen. But we are taking as many precautions as we can, which is why we believe virtual health is critical. We can flex that up and down depending on what's happening in our facilities. But we do know that in the state of Wisconsin right now, there are children in the intensive care unit with enterovirus infection. These are viral infections that look a lot like COVID. So it's going to be a huge challenge, but testing capability is going to be extremely important. Continuing to take the precautions that we can to avoid contracting illnesses in general, which for COVID has included masking, but certainly good hand washing techniques and not coming to work when you're sick. But it is, and we don't know what the status of the vaccine is going to be. And we have to wait and see what is going to be happening with the companies that are developing these immunizations and whether they will be effective and how they would be distributed. So there are, this is multifaceted, a very complex problem. And we monitor it probably not even day to day, it's minute to hour. And Jeff and others are part of those conversations. So what we try to do is get information out to our staff, to our leadership, to our boards, and to our communities, to our community work, and we'll continue to do that. I'd love to make a promise that it won't be a problem in the fall. I would find it hard to believe. The question is, what will the magnitude of it look like? So stay tuned. We'll keep you informed, and we can have people come on and talk about this in more detail about how this process is unfolding.
Yeah, I think that's a great answer, and certainly part of the forum here that we have is to communicate in different ways, and that's been one of the benefits of doing these webinar Wednesdays over the last several months, and why we want to continue the discussion and the dialogue with all of our guests and participants. So thank you again. Thank you, Susan, for your participation today and your presentation. It was great. Again, this is on our website, or will be shortly. Ashley will send it out to all of you as well. We will also follow that up with a survey. We do want to hear from you and hear more about what you want to hear about, so that we can make sure that we're bringing you the valuable content you need. But I think this last question actually kind of gears us up for some future discussions we'll be having as it relates to flu. And it's something that I know Jeff and I and others have been talking about as we do flu clinics out there with our employers. And maybe at some point we'll be doing COVID clinics as well, with immunizations that way. But I guess that remains to be seen. So with that, we're well over our time, but I think it was really valuable time. Thank you, everybody, for your participation today and for your questions. Susan, again, thank you very much for coming on, and we look forward to having you come on again. Jeff, anything you want to add?
One thing, Dr. Turney mentioned the iPad donation program. If you know of a patient in need, or you have an iPad you want to donate, our contact information goes out with the materials that we email after this. Just contact Chris or myself or Ashley, and we'll connect you with the right resources within our system.
Perfect. Thank you very much.
Thanks, Chris. Thanks, Jeff. Thanks, Ashley.
Thank you. All right. Have a great day, everybody. Be well. Bye-bye.
Thank you.